All right, welcome back to another explainer. Today we're going to unpack the incredibly high-yield taxonomy of biliary tract diseases. We're going to organize them from congenital all the way to autoimmune. If you're currently preparing for your United States medical licensing exams, or honestly, if you just want a rock-solid, structured understanding of hepatobiliary pathology, you are in the exact right place. We're going to cover all the major diseases, hit those absolute must-know buzz points for the boards, and break down all this complex pathophysiology into bite-sized, highly visual pieces. Let's get to it. Okay, let's kick things off with a real-world scenario. Meet Stella Murphy. She's a 50-year-old woman referred to the clinic because of elevated liver function tests. She's complaining of fatigue, dry skin, and intense pruritus, that's severe itching, that started almost 2 years ago. Interestingly, she also has a history of Sjogren's syndrome. Now, when we examine her, there's no jaundice, no palpable masses, and no hepatosplenomegaly. But her labs, well, her alkaline phosphatase and GGT are markedly elevated. I want you to keep Stella's profile in the back of your mind as we go through this. What's causing this? Is it an infection, a structural block, maybe an autoimmune attack? We'll solve this mystery by the end. So to map out this entire biliary landscape and figure out what's happening to Stella, here is our quick agenda. First, pediatric cholestatic syndromes, then fibropolycystic liver diseases, followed by autoimmune biliary diseases, extrahepatic biliary tree diseases, and we'll wrap it up with our case resolution.
Starting with Section 1, Pediatric Cholestatic Syndromes. First up on our list is biliary atresia. Now, the absolute crucial point you need to know here is that infants with biliary atresia are actually born without jaundice, but they develop it super rapidly within the first 2 months of life as their extrahepatic ducts become completely obliterated. You'll start to see dark urine and progressively pale stools. So why does this happen? Well, the current working hypothesis is that some sort of prenatal environmental insult, think a virus or a toxin, damages the bile duct in a genetically susceptible fetus. Then that injury just keeps progressing after birth, triggering this massive autoimmune-like destruction. To really visualize this, look at the comparison here. With biliary atresia, the extrahepatic ducts, both the common bile duct and the cystic duct, are entirely atretic. That means they are completely narrow, totally non-functional, and reduced to these tight fibrotic cords with literally zero lumen. Contrast that with a choledochal cyst, where you see a massive fusiform dilation of the common bile duct. And then there's idiopathic neonatal hepatitis, where the actual duct architecture is perfectly fine, but the liver parenchyma itself is packed with these giant syncytial cells. Okay, if you're prepping for the USMLE, you absolutely have to anchor these pediatric buzzwords into your memory. For Alagille syndrome, you must remember the JAG1 gene mutation, which messes with Notch signaling. If you look at a biopsy, you'll see a paucity, or a severe lack, of interlobular bile ducts. Systemically, be on the lookout for cardiac murmurs, butterfly vertebrae, and a very specific corneal opacity called posterior embryotoxon. Moving to idiopathic neonatal hepatitis, or INH, your big buzzword is syncytial hepatic giant cells. This is basically a non-specific response where injured immature hepatocytes just fuse together, but examiners love it. The good news for INH, 75 to 90% of cases actually recover by age 1. And finally, for biliary atresia, you've got to know the Kasai procedure, officially called a hepatoportoenterostomy. Because those extrahepatic ducts are totally destroyed, the surgeon actually removes them and attaches a piece of the patient's small intestine straight to the liver to get that bile flowing again. But just keep in mind, even with this surgery, 70% of these kids will eventually need a full liver transplant.
All right, moving right along to Section 2, fibropolycystic liver diseases.
Let's look at the plumbing mechanics behind a chodochal cyst because the domino effect here is truly fascinating. For your exams, remember this is much more common in Asian populations, specifically females, about a 1:4 male-to-female ratio. It all kicks off with an anomalous, unusually high junction between the common bile duct and the pancreatic duct. Now, hydrostatic pressure in the pancreas is 2 to 3 times higher than in the biliary system. Because of that pressure difference, you get pancreato-biliary regurgitation. Pancreatic enzymes literally shoot backward into the bile duct. This causes severe inflammation, recurrent cholangitis, and eventually a massive fibrotic dilation. Clinically, you're looking for a classic childhood triad: intermittent abdominal pain, a palpable right upper quadrant mass, and jaundice. What's wild is how visually distinct these fibropolycystic diseases are. Take Carolate disease. You get these massive segmental cyst-like dilatations of the large intrahepatic bile ducts. Bile stagnates in these huge spaces, forming stones and causing some really severe infections. Compare that to von Mayenburg complexes. These are tiny, uniformly small cystic lesions, usually less than half a centimeter. The keyboard exam differentiator, von Meinberg complexes do not communicate with the normal biliary tree, so patients are completely asymptomatic. It's usually just an incidental finding. And then there's congenital hepatic fibrosis. This one causes abnormal branching of portal veins, which leads to severe portal hypertension, so think splenomegaly and esophageal varices in a child. But importantly, their actual hepatic synthetic function, like their bilirubin and albumin levels, stays perfectly normal.
Okay, before we leave this section, you have to burn this high-yield warning into your brain. If a patient has a fibropolycystic condition, their risk for cholangiocarcinoma, which is cancer of the bile ducts, absolutely skyrockets. In Caroli disease specifically, the risk of developing this cancer is reported to be up to 100-fold greater than in the general population. That is a massive, massive red flag association that you have to know for test A.
Let's shift gears now to Section 3, autoimmune biliary diseases.
Pay close attention here, because this head-to-head comparison is arguably the most vital distinction you can make in this entire explainer. Examiners absolutely love testing your ability to tell PBC and PSC apart. So primary biliary cholangitis, or PBC, is overwhelmingly a disease of middle-aged women. We're talking a 10-to-1 female-to-male ratio. It selectively attacks the small intralobular bile ducts, and the absolute gold star marker? That's the antimitochondrial antibody, or AMA, which you'll find in about 95% of these patients. It's also frequently associated with other autoimmune diseases, like Sjogren's syndrome and Hashimoto thyroiditis. In the other corner, we have primary sclerosing cholangitis, or PSC. This mostly affects younger men, usually around 30 to 40 years old. Instead of just hitting the small ducts, PSC goes after the medium and large ducts, both inside and outside the liver. Their key marker is PANCA, showing up in about 84% of patients. And the association they test all the time? 70 to 80% of PSC patients have inflammatory bowel disease, specifically ulcerative colitis.
If we look at PBC on a cellular level, it's pretty wild. Early on, there is an intense T-cell-mediated attack directly on the portal tracts. You've got CD4 and CD8 T-cells surrounding and destroying the small bile ducts, and they often form non-caseating granulomas. The leading theory for why this happens is molecular mimicry. Basically, an environmental trigger, like maybe a bacterium, has a protein that looks exactly like a mitochondrial enzyme in the human body, and it kicks off this massive friendly fire event. As the disease progresses, you get a complete loss of native ducts in the portal tracts, a state called ductopia. And finally, all that chronic cholestasis leads to a buildup of toxic bile acids. Those acids destroy the surrounding hepatocytes, leaving you with a green, bile-stained micronodular cirrhosis. PSC, on the other hand, leaves behind very different footprints. The absolute classic hallmark here is concentric onion skin fibrotic rings wrapped around the bile ducts. This fibrosis completely chokes off the lumen, leaving behind what we call a tombstone scar right where the duct used to be. Because this fibro-obliterative process targets the large ducts, it creates these multifocal strictures. If you do an ERCP, which is the gold standard diagnostic tool here, you'll see a highly abnormal biliary tree. It has tight strictures alternating with dilated ectatic segments. We call this the classic beading appearance.
Moving outside the liver, here is Section 4, extrahepatic biliary tree diseases.
When it comes to large extrahepatic blockages, the most common culprit is choledocholithiasis. That's just a fancy word for gallstones stuck in the common bile duct. For the exams, keep the two types straight. Primary stones are usually brown pigment stones that form right there within the bile ducts, usually due to stasis or an infection. Secondary stones, however, are usually cholesterol stones that formed up in the gallbladder and just migrated their way down into the duct. In developed countries, over 85% of these are those secondary cholesterol stones. Now, stones can be totally silent, but a blockage here can cause severe biliary colic and rapidly escalate into a life-threatening systemic problem.
And that life-threatening problem is ascending cholangitis. If the duct is blocked by a stone, bacteria from the duodenum can actually ascend right past the sphincter of Oddi and into the biliary tree. The most common offender here is E. coli. Pus starts accumulating, pressure builds up, and it forces bacteria and toxins directly into the bloodstream, triggering septicemia. If you see a patient on an exam or honestly in the ER with this kind of obstruction, you are looking for the classic Charcot triad: right upper quadrant abdominal pain, jaundice, and a high fever with shaking chills. When you see that triad, you're looking at an immediate medical emergency that requires antibiotics and rapid biliary decompression.
So what happens if an extrahepatic blockage is just left untreated for a long period of time? The patient develops secondary biliary cirrhosis. It doesn't matter if the blockage is from a pediatric atresia, an adult gallstone, or a stricture from PSC. The underlying mechanics are exactly the same. Chronic back pressure builds up,
Those retained hydrophobic bile acids are actually highly toxic detergents. They literally dissolve cell membranes, trigger hepatocyte apoptosis, and induce feathery degeneration and bile infarcts. The liver essentially drowns and destroys itself in its own toxic bile, which leads to widespread fibrosis and shrinking of the liver.
All right, Section 5, it's time for our case resolution. Let's bring it all back to Stella Murphy and look at the evidence we gathered. She's a 50-year-old female. She complained of severe pruritus, which we now know is a super common and distressing symptom of cholestasis. That's bile acids backing up and depositing right into the skin. She had elevated alkaline phosphatase and GGT, which screams biliary tract involvement. She's got a history of Sjogren's syndrome, and the absolute clincher, her serology showed highly elevated anti-mitochondrial antibodies, or AMA. When you match up her specific demographic, her autoimmune history, the positive AMA, and a biopsy showing ductopenia of those small interlobular ducts, boom, we can confidently diagnose Stella with primary biliary cholangitis.
So what's next for Stella? We'll get her started on ursodeoxycholic acid, or UDCA. This is actually a non-toxic bile acid that helps replace the toxic ones circulating in her system. It significantly slows down the progression of PBC and can delay the need for a liver transplant by up to 20 years. But while Stella's journey is managed, it's not totally cured. And that leaves us with a really provocative question. With everything we now know about T-cell mediation and molecular mimicry, how close is medical science to finding the exact genetic or immune target to definitively halt these runaway immune responses right at their source? It's a massive question, and researchers are trying to crack it open right now. Keep these distinct demographics, imaging findings, and buzzwords sharply organized in your mind, and you are absolutely going to crush this topic on your medical licensing exams. Thanks so much for joining me on this explainer, and keep studying hard.